represents the spectrum of disease ranging from gestational hypertension to preeclampsia with or without severe feature. Because the potential complication associated with preeclampsia, all patients with hypertension more than 20 weeks of gestation require preeclampsia evaluation, blood pressure measurement, clinical signs of organ damage like headache, visual changes, right upper quadrant pain, and lab signs of end organ damage, urine analysis, creatinine, transaminase, platelet count, and fetal well-being. Although this patient has normal lab evaluation, urine analysis show only 1 plus protein. More than 2 plus is diagnostic. The diagnosis of the preeclampsia is not definitely excluded because urine analysis has high rate of false negative due to small urine sample size compared to the daily lot of total urine output. Therefore, patients with new onset hypertension and absent or minimal proteinuria or urine analysis or urine dipstick require 24-hour urine collection of total protein, the gold standard, to evaluate for diagnosis to exclude the preeclampsia. Okay, next. So this patient's exertional symptoms: dyspnea, angina, and echocardiography revealing left ventricular hypertrophy, or left ventricular hypertrophy primarily affecting the interventricular septum, most likely has hypertrophic cardiomyopathy. Common presentation, common presentation, common physical findings in HCM include prominent left ventricular impulse and S4 and crescendo decrescendo systolic murmur based heart at the left sternal bottom. Most patients with HCM most patients with HCM have dynamic left ventricular outflow tract obstruction that varies with the change in the left ventricle volume The obstruction is worsened by relatively low blood volume improved by improved by high left ventricular volume. Therefore, management aims to maintain relatively high left ventricular volume. One way is accomplished by avoidance of dehydration. That in addition, medication with negative chronotropy and negative ionotropy benefit HCM by uh, negative chronotropy and negative ionotropy benefit HCM, increasing left ventricular volume in the following way. Negative chronotopy slows the heart rate, increase left ventricular volume, slows the heart rate, increase left ventricular volume, and increase left ventricular end diastolic volume. And negative inotropy reduces left ventricular contractility to allow systolic ejection to complete at a higher left ventricular volume, increase left ventricular end diastolic volume. These effects increase left ventricular volume throughout the cardiac cycle to help reduce outflow tract obstruction. Beta blockers, metoprolol, are usually first-line therapy. However, they are relatively contraindicated in patients with obstructive lung disease, asthma. In patients with HCM, a contraindication to beta blocker, verapamil is often used. A contraindication, verapamil is often used to decrease the chronotopy and the inotropy. Okay. Yes. Okay. This patient with sudden onset, this patient with sudden onset, mm, sudden onset severe leg pain and signs of arterial occlusion, cold, mottled leg, lacking pedal pulse, has acute limb ischemia. Although acute limb ischemia is often due to thrombosis plaque, it can also be caused by embolism thrombus. Given this patient recent anterior ST elevated MI, his ALI acute limb ischemia is most likely due to embolization, most likely due to embolization of a left ventricular mural thrombus. Patients with patients with a large anterior ST segment elevated MI from occlusion of the proximal LAD are the highest risk for left ventricular aneurysm formation, especially when reperfusion therapy is unfeasible or delayed. Treatment initiated after 8 hours of ischemia in this patient. When a left ventricular aneurysm forms, the infarcted muscle when and left ventricular aneurysm forms, the infarcted muscle fails to contract or even balloons outward during systole and is associated with low ejection fraction and stasis of adjacent blood. These may lead to formation of left ventricular thrombus and em- that can embolize, causing stroke or acute limb ischemia in this patient. In addition, emergency treatment of acute limb ischemia, heparin infusion, vascular surgery consultation. This patient should undergo transthoracic echocardiography with contrast to assist for a left ventricular aneurysm and or residual thrombus. The presence of either findings may impact the duration of anticoagulation. Yes. Uh, Option A, ongoing recent intravascular coagulation and fibrinolysis can cause elevated D-dimer, product of fibrin degradation. Although D-dimer might be elevated in this patient with left ventricular thrombus, the test is non-specific and can be evaluated from several other conditions. The test is non-specific and can be evaluated from several other conditions: malignancy, pulmonary thromboembolism, infection. So it is non-specific.
Mhm.
That's why, and it is clear cut, like this patient has ST elevated MI. Now ST elevated MI, so PCI done. Now after 6 days there is leg pain, severe leg pain. So looks like acute limb ischemia. So as he has already ST elevated MI, so maybe any sort of thrombus or any sort of thrombus may dislodge into the leg vein and causing this acute limb ischemia. That's why um, transthoracic echocardiography with contrast to assess the left ventricular aneurysm and residual thrombus. Okay. Option C, heparin-induced thrombocytopenia typically occurs 5 to 10 days after initiation of the heparin therapy. Patients with heparin-induced thrombocytopenia are prone to thrombus, and venous is more common than the arterial thrombosis. However, lower extremity venous thrombosis, which can be detected with venous Doppler study, typically causes swelling and or warmth. Yes. Okay, it's continuous murmur, PDA, and it is best heard at the left infraclavicular and posterior interscapular region. Best heard at the left infraclavicular or left interscapular region. Um, okay. Option A, endocardial cushion defect. I am not reading the explanation because this whatever we read, this type of question actually can be dealt with the murmur auscultation. Okay, listen to the if it is the endocardial cushion defect, listen to the ASD. Listen to the ASD murmur. The typical murmur of ASD is not caused by endocardial cushion defect are common with the Down syndrome, septum primum defect, and can cause ASD. So listen to the ASD murmur. ASD has wide and fixed splitting. Yes. Okay, no problem. We can move on. There are, sorry, yeah, no, look, you have read the explanation, and I have make you seen like it is best heard in the left infraclavicular or posterior interscapula region, but they have uh, in here there is left sternal border. Got it? So not matches with the description. Because in left sternal border, what are the normally, if normally we think left sternal border, what are the murmurs we get? We get AR murmur, we get PR murmur, we get like VSD murmur, isn't it? Yes. So not matches with the explanation. I think that they are trying forcefully to make some mistakes because hearing it is tough for cardiologists too, just hearing the murmur, because nowadays when somebody is suspicious about murmur, they actually do echo, and echo actually tells you the story. Okay. Okay, this is sternal dehiscence. This patient's presentation is concerning for sternal dehiscence, a complication of the cardiac surgery when two approximated ages the bony sternum separate, typically due to loosening or fracture of the suture wire. Fracture of the suture wire, it can occur with or without involvement of superficial soft tissue, superficial dehiscence, or concurrent deep infection, mediastinitis. Pa- Patient may have mild pain and a sensation of the chest wall instability or clicking with chest movement The diagnosis can be made radiographically and displaced. The diagnosis can be made radiographically, that is displaced sternal wires, and clinically palpable rocking or clicking the sternum. Palpable rocking or clicking the sternum confirm the diagnosis. So this word like palpable rocking or clicking the sternum confirms the diagnosis, and radiographically by displaced sternal wires. Okay. Risk factors are related to impaired wound healing, obesity, macrostomia, large breasts, and the sequelae of the COPD, barrel chest deformity, chronic cough, increased tensile forces on the wound closure, predisposing patients with sternal separation. Internal thoracic artery harvesting can result in sternal ischemia, whereas patients with diabetes and who smoke are at risk for poor wound healing and infection. Sternal dehiscence is a surgical emergency and requires urgent surgical exploration, debridement, and sternal fixation to prevent cardiac damage from loose wire or bone fragments. Patients without evidence of underlying infection can undergo rewiring or sternal plate placement to stabilize the sternum. Got it? Okay, it's not option B and C. Compressive sternal dressing and negative pressure wound therapy. Compressive sternal dressing and negative pressure wound therapy are frequently used in patients with sternal wound failure to protect the wound and speed its healing. However, this patient has palpable rocking of the sternum consistent with sternal dehiscence and therefore requires surgical intervention and sternal fixation to prevent cardiac injury. Okay? Yes. Okay. Look at the PR interval.
Mhm.
PR interval. Okay, I am sharing my screen. It will help you.
Mhm.
In lead V1, And what are the PR interval? So from here the P starts this point. Can you see my cursor? So this is the P and this point is QRS, isn't it? So how many small square is present? 5, 6, 7, 8, near about 8. And look at this again. And normal PR interval is 3 to 5. If it is more than 5, it is uh, like what can I say? PR prolonged. Yes, PR prolonged. So in here, P starts with in here. How many? Near about again the 7 or 8. From here, if you count 5, 7 or 8, so PR prolonged and equal. So if PR is prolonged and equal, it is first degree AB block. So in first degree AB block, we actually don't do anything, just observe. Look at this point. Yes. Yeah. So they are measuring the PR interval. Uh, so onset of P wave to onset of the QRS complex. So 5, 6, 7, 8, near about 8. So we have counted the 8. Got it? So this way you can diagnose. Equal. PR prolonged and it is actually equal. PR prolonged. That's it. No drop. No drop. Yes. In a Mobis type 1, like second degree block. Second degree block has two type, Mobis type 1 and 2. In Mobis type 1, there is progressive prolongation of the PR interval. That means PR is prolonging one by one. If we lead by lead, you will see that PR is prolonging. Then a drop bit you will find. And Mobis type 2 is constant PR interval with a random dropped QRS. And third degree is atrial rate is more than the ventricular rate. P wave not followed by the QRS complex. Yes. Okay. Next. Okay. So management of the adult tachycardia with a pulse. So sustained rapid tachyarrhythmia. Sustained rapid tachyarrhythmia area management. Supplemental oxygen needed. Excess cardiac rhythm. If sinus tachycardia, yes, seek for the cause and treat. If no sinus tachycardia, patient is hemodynamically stability present or not. This patient is hemodynamically unstable. So in hemodynamically unstable patient, synchronized cardioversion should be done. If the patient is hemodynamic stability present, no hemodynamic stability present, then you have to look for the QRS complex. If QRS complex is wide, wide and QRS complex and regular rhythm, most likely monomorphic VT. If QRS complex is wide, regular rhythm, but no regular rhythm, so it may be atrial fibrillation. So regular rhythm is atrial fibrillation or SVT, and irregular rhythm like not regular rhythm is atrial fibrillation or flutter type. Got it? So first of all, in this, if somebody, if you find a patient with tachycardia, then do IECG. Like first you do the ABCD, then you do IECG. If it is sinus tachycardia, in ECG it is easily diagnosed that P wave present and rate is more than 100 but less than 150, it is sinus tachycardia. Then think about the cause of the sinus tachycardia, like hyperthyroidism can cause sinus tachycardia. So treat that particular cause. If it is no, if the patient is hemodynamically unstable, then synchronized cardioversion. Okay, next.
So the ED
Okay, taking too much time. Okay, blunt chest trauma. Blunt chest trauma. If the patient is hemodynamically unstable, resuscitation and evaluation. E fast chest X-ray ECG with or without stabilizing intervention like chest tube if indicated. Hemodynamically unstable patient resuscitation and evaluation. E fast chest X-ray ECG with or without stabilizing intervention chest tube if indicated. Hemodynamic stability achieved maintained. No. Hemodynamic stability achieved or maintained. No. go to OR for thoracotomy. If hemodynamically stability achieved, yes. Additional test is CT, and abnormal findings on evaluation like chest X-ray, ECG, no. Possible discharge for observation. If the patient is hemodynamically stable, high risk mechanism or serious injury on examination, we have to evaluate all the EFAST, chest X-ray, ECG. So basically, when any patient comes with a blunt chest trauma, we as fast as do EFAST for any sort of accumulation or any sort of injury present or not. Then we are doing X-ray because blunt chest trauma can cause tension pneumothorax, and then we can do ECG. If ECG is abnormal, then we have to think about other things like chest tube should be given. Okay, do you want me to read the explanation?
Yes, please.
Okay, this patients this patient involved in a high risk motor vehicle collision and has anterior chest wall pain and tenderness concerning for blunt chest trauma. He is hemodynamically stable and his chest X-ray and fast extended fast uh, are normal. The next step is to obtain an ECG to screen for blunt cardiac injury. For patients with blunt chest trauma, hemodynamic stability or instability determines the management strategy. Hemodynamically unstable patients undergo simultaneous resuscitation and evaluation chest X-ray fast to look for life-threatening injury. Stabilizing intervention are performed for any abnormalities identified chest tube for pneumothorax in stabilized patient. Additional testing, chest CT scan are obtained to assess for further injuries that could be missed on initial evaluation. Aortic injury patients who remain unstable are taken directly for operating room thoracotomy. In hemodynamically stable patient, the extent of workup is determined by the mechanism of the injury. Initial examination. Patients without high risk mechanism with no serious injuries on examination, normal heart sound, lung sound, undergo ECG and chest X-ray. In patients with abnormal finding, like interventions are performed, chest tube for pneumothorax, and additional tests, chest CT scan are obtained. Whereas patients without abnormalities can be safely discharged with analgesic and detailed return precautions. Patients such as this one who are hemodynamically stable but have high risk mechanism, unrestrained vehicles with significant damage, or those who have serious injury or examination should be treated similarly to hemodynamically unstable patient. Therefore, in addition to EFAST and chest X-ray, these patients should have an ECG performed. Okay, next.
Oh,
You want, okay, ECG can help to evaluate blunt cardiac injury, which most commonly occurs due to rapid deceleration with MVC. Uh, sorry, and can cause tamponade or wall rupture. Be clinically silent. Sinus tachycardia, arrhythmia, or ST changes may be seen. Abnormal ECG is followed by observation for approximately 24 hours. that is a risk of fatal arrhythmias, in addition to cardiac enzyme testing, echocardiography to rule out the cardiac tamponade. Yes, yes. He has so no look wait, he has, first of all, when the MI happened, MI happened how for how long? 4 months ago. So one complication, think about one by one. So the usually the pitfall, think about pitfall first. In pitfall, papillary muscle rupture, interventricular septal rupture, uh, free wall rupture, and a left ventricular aneurysm. So left ventricular aneurysm when happened, or month? Yes. So it may be because LV aneurysm can come with the ECG finding. In here, when you find, look at this ECG again. In ECG, lead V234. These are. Do you know what that is? It is not R. It is actually a deep S. Sorry, deep Q. When there is earlier MI, like when there is previous MI. Suppose somebody has MI uh, 2 months, 3 months ago. Then how will you assess that this patient has MI? We will see the Q wave, the V234, the uh, long downward deflections are the Q wave actually. This is ST segment elevation. So ST elevation and deep Q go for aneurysm. Just two things. Yes, both need to be together because uh, think about in this way. In ECG, when ST segment is elevated, it is not elevated for forever. It's not like TPHA. Like one you have once somebody has SLE, it is SLE for lifelong. It is not like ST segment elevation. ST segment elevation in the ECG, when there is ST segment elevation, it will comes down when you are treating the patient. Got it? So if you find two things at a row, like deep Q along with persistent ST elevation, go for aneurysm. And first of all, you have to see when the MI happened. You have to make an assessment of the time duration. If the MI happened for a long period ago, like 3 months, 4 months. Like in left ventricular aneurysm, there is a word saying that months to years. So it can happen after an year also. So yes, yes. In the description somewhere it is written it can happen months to years. In the box, the important box, what we have read in there also. So if you find deep Q along with persistent ST elevation in the V2, 3, 4, like in the chest lead, L1 to 3 is the limb lead and V1 to V6 is the chest lead. Okay, so I am reading the explanation now. Okay. This patient has developed heart failure, likely due to left ventricular aneurysm. Ventricular aneurysm is a late complication of the myocardial infarction that can occur up to several months following transmural ST elevation, transmural MI, and a delay in the coronary reperfusion increasing the risk. The healing process of the MI results in replacement of necrosed myocardium with a fibrous scar, which in the case of large MI can result in the convexity of the large population of the left ventricular valve, most commonly in the perfusion field of the left anterior descending artery. The aneurysm is dyskinetic with the remaining healthy ventricular valve, resulting in impaired ejection fraction. Although heart failure, jugular venous distension, pulmonary crackles is the most common presentation, angina may also occur due to increased oxygen demand caused by elevated wall stress in the setting of an enlarged left ventricle. Ventricular arrhythmia or ventricular arrhythmia or systemic embolization due to mural thrombus inside the aneurysm is possible as well. Classic ECG findings include persistent ST segment elevation, deep Q waves in the leads corresponding to the previous MI, and diagnosis is confirmed by echocardiogram showing a thinned and dyskinetic myocardial valve. Got it?
Just to just in a normal
Is is it distributive shock,
is
anaphylaxis?
anaphylactic
It is also distributed shock.
Is
In distributive shock or anaphylactic shock, everything is going down except two. Like this is a unique difference in like cardiac index is increased, like left ventricular output is increased, and mixed venous oxygen consumption is increased. This too is increased only in distributive shock, and the rest of the CBP, PCWP, and the SVR all is decreased. That's it. Next,
okay. Starting
I'm calling you within a minute. Yes. Okay. Hello.
Yeah, I can hear you.
Yes. Okay. You haven't shared screen. Okay.
Do you see it now?
Yes. So this patient has signs of heart failure, gallop rhythm, rals, poor perfusion in the setting of upper respiratory viral symptoms, finding concerning for myocarditis. These potentially fatal inflammation of the myocardium. These potentially fatal inflammation of the myocardium is most commonly caused by viral infection, Coxsackie B virus, Coxsackie B virus, and adenovirus. Myocyte necrosis occurs via direct viral injury and/or immune-mediated inflammation and can result in impaired systolic and diastolic function. A viral prodrome often precedes the illness, as seen in this child with fever, rhinorrhea, congestion, cervical lymphadenopathy. Patients then typically develop fatigue, tachycardia, respiratory distress, retraction, nasal flaring, tachypnea, crackles, with hypoxemia from acute left heart failure and pulmonary edema. Because symptoms overlap with common viral illness, the diagnosis is challenging and may be delayed. However, progressive symptoms leading to dilated cardiomyopathy with secondary MR can cause S3 gallop and hollow systolic murmur as seen here. Reduced cardiac output can lead to hypotension, decreased peripheral pulse, and oliguria. Hepatomegaly can also occur due to progressive congestion from the right-sided heart failure. Initial workup includes cardiac enzyme (ECG), chest X-ray echocardiogram. Chest X-ray reveals cardiomegaly and bilateral hazy opacities. Echocardiogram often shows diffuse hypokinesis with decreased ejection fraction. Endomyocardial biopsy or cardiac MRI is needed to confirm the diagnosis, and treatment. Diuretics is often initiated based on the clinical suspicion. Next. Okay, it's not acute rheumatic fever. It can cause fever, myocarditis, but Jones criteria like joints, migratory arteries, oh my heart, carditis, and nodule, E for erythema marginatum, and S for sydenham chorea would be present. In addition, acute rheumatic fever occurs weeks after untreated group A streptococcal pharyngitis, whereas patients with rhinorrhea and congestion is a sign of concurrent viral illness.
Yeah. After this, maybe preference because of illness, coronavirus without diagnosis, because of infection. The patient was initially severe hypotension. These days, the patient is in a stable condition.
Okay, this patient has sudden onset. This patient has sudden onset apparent loss of consciousness and postural tone concerning for syncope. However, several features suggest psychogenic pseudosyncope. Psychogenic pseudosyncope, a type of conversion disorder rather than syncope. Syncope occurs due to global cerebral hyperperfusion. In contrast, psychogenic pseudosyncope is an apparent transient loss of consciousness without impaired cerebral perfusion. Although no single clinical findings conclusively defines the psychogenic pseudosyncope, it is commonly associated with the following features: prolonged loss of consciousness, more than 20 minutes. Psychogenic pseudosyncope episodes typically last and absence of object finding during these episodes, and patient report the symptoms or events that occurred during these episodes. Like I felt my head throbbing after I hit the floor. So if these features is present, like prolonged loss of consciousness and the absence of object finding during the episodes, and absent of object finding, that means there is no abnormal vital sign, pallor, sweating, and patient report symptoms that occurred during these episodes, like I felt my head throbbing after I hit the floor. Okay, if these are the features present, so think about conversion disorder. Okay, differentiate from vasovagal syncope. In vasovagal, option E, in vasovagal syncope causes loss of consciousness, often preceded by a prodrome nausea, often preceded by nausea. Episodes are typically brief, less than 2 minutes. Patients do not describe the events that occur during the unconsciousness. I felt my head throbbing after I felt my head throbbing after it hit the floor. So they cannot describe these sort of events. Got it?
How severe is it more than 20 minutes continuous syncope? The patient describes
Okay. These patients' fatigue, dyspnea, and fluid retention are consistent with heart failure and consistent with heart failure. Several features suggest in this case the most likely diagnosis is cardiac amyloidosis. Amyloidosis that involves the heart is usually caused by amyloid transthyretin or amyloid light chain. Amyloid transthyretin occurs in both hereditary and age-related forms and commonly affects the nervous system. Carpal tunnel syndrome in associated in addition to the heart. Amyloidosis can affect the heart and many other organ systems, kidneys, liver, skin, GIT, peripheral nerves, and is most likely in this patient with proteinuria and apparent early satiety, abdominal fullness, decreased appetite. Myocardial infiltration by amyloid protein typically create stiff and thickened ventricular wall manifesting as restrictive cardiomyopathy. Echocardiographic evidence of concentric left ventricular hypertrophy, especially in the absence of hypertension, can be a helpful clue. Diastolic filling Diastolic filling of the left ventricular diastolic filling of the left ventricle is impaired, causing elevated hydrostatic pressure to back up and lead to biatrial enlargement, pulmonary edema, and signs of right heart failure. Jugular venous distension, ascites causing abdominal distension with flank dullness, lower extremity edema. Left ventricular ejection fraction is typically preserved or may be increased. Heart failure with preserved ejection fraction, a small pericardial effusion is common, possibly resulting from inflammatory response to infiltrating amyloid. Okay,
Okay.
sorry. Okay,
Okay.
deficiency. Thiamine deficiency can lead to high output heart failure, which demonstrate ventricular cavity enlargement on echocardiography. Thickened ventricular walls are not expected.
Okay. Next,
Yes.
according to your main growth related heart related question, which hospital specialized in cardiovascular
I was sure that it is temperate. Even if I am sure, I changed my answer. You have done the same mistakes like me. A tamponade has a feature like hypotension, tachycardia, distended neck vein. I am looking for distant heart sound. If I found the distant heart sound, I will go for the tamponade. Oh, this is the problem in my exam. Even if I am sure, I change the answer and that goes wrong. But lots of people who are giving exam, they have said that like don't change the answer. Like whatever you say, whatever you thought first, that is the correct answer most of the time. And they are saying that exam is not that tough, but we actually do a blunder because 8 9 hours concentration is very tough. No, no, yes. So at a stretch, 1 to 2 blocks can be doable, or 3 to 4 blocks, but 8 7 8 blocks is tough. Yes. Okay. This patient with refractory hypotension, tachycardia, and jugular venous distension likely has acute cardiac tamponade. Acute cardiac tamponade due to blunt cardiac injury. Cardiac tamponade is classified as acute or subacute based on the rate and volume of the pericardial accumulation based on the rate and volume of the pericardial accumulation. Subacute tamponade is typically develops Subacute tamponade is typically develops for chronic process that causes the slow accumulation of the pericardial fluid, malignancy, renal failure, giving the pericardium time to progressively stretch. So this large quantity of the pericardial fluid causes classic globular cardiac shadow on X-ray. Globular cardiac shadow on X-ray. In contrast, acute tamponade occurs due to rapid accumulation of blood due to blunt cardiac injury in this patient because the stiff pericardium does not have time to adapt. A small amount of pericardial fluid, 100 to 200 ml, can dramatically increase intrapericardial pressure without causing cardiomegaly on X-ray. Therefore, acute tamponade is associated with normal cardiac contour as in this patient. Okay. Okay. On physical examination, patients may have hypotension, elevated jugular venous pressure, as well as muffled heart sound, big striatum, often seen a minority of the patient. These patients' small left-sided pleural effusion may be due to blood leaking from pericardium through the small tear or a concomitant injury, lacerated lung parenchyma. Next. Okay. So he has non-ST elevated MI. Non-ST elevated MI. The next thing you need to do, you can give like a low molecular weight heparin, IV heparin can be given. The following pharmacological agent can be given. Uh, okay, nitrate, rapid chest pain relief, caution with hypotension, RV infarction. Beta blocker, cardioselective metoprolol, lateral. It is contraindicated in cardiogenic shock and bradycardia. If patient has bradycardia, cardio box, beta blocker.
Okay.
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 If we read the box, we can assess this question. Okay. So nitrates cannot be nitrate should be given in caution with hypotension or RV infarction. Beta blocker, cardioselective metoprolol, it decreases myocardial oxygen demand to limit infarct size. It is contraindicated in cardiogenic shock and bradycardia. Antiplatelet therapy, aspirin, P2Y12 inhibitor, prasugrel and clopidogrel. It reduces platelet activity. Anticoagulation are fractionized heparin, bivalirudin, enoxaparin. It limits thrombus expansion. And the statin therapy, high potency atorvastatin, rosuvastatin, stabilizes atherosclerotic plaque. And coronary reperfusion, ST limited MI, PCI less than 90 minutes from first medical contact. Fibrinolytic alteplase if PCI is unavailable, non-ST limited MI or unstable angina. Coronary angiography often within 24 hours. Got it?
Amazing. Next thing is to continue.
Okay. We can catch later. Okay, bye bye.